upon Dr. B.T. Arish upon the stage. So he did his MBBS MD anesthesiology fellowship from Ganga Hospital in regional anesthesia and pain management from Daradia. He is presently Associate Professor, Department of Anesthesiology, Pondicherry Institute of Medical Sciences. He has various articles and publications. His areas of interest are acute and chronic pain management, difficult airway, and geriatric anesthesia. He was a faculty and resource person in various state conferences and workshop coordinator, and also a PG focus moderator. So the mic is yours now.
Hello. Yes. Thank you, sir. Thank you for the introduction. My today's topic is on segmental spinal anesthesia. Before going into the topic, I just wanted to express my gratitude towards the organizers for giving me this opportunity. So, greetings from Pondicherry Institute of Medical Science. This is a 750-bedded multi-specialty hospital and higher referral state in our state. I have no conflicts of interest towards this topic. So coming to the topic is segmental spinal anesthesia. The word segmental spinal will always be similarly used with the thoracic and the lumbar segmental spinal. So there is no any proper definitions for it. So we can just say, as the name indicates, a segmental spinal, it's blocking of the required dermatomes essential for the proposed surgical procedure with a very low effective local anesthetic drug. Since it has gained a very high interest and popularity from the pandemic till now because of its cost effectiveness, and it avoids the post-operative pulmonary complication in high-risk patients when compared to general anesthesia. So though it is not started just during the pandemic, it's almost more than a century ago. It has been started by Thomas Jonesco in 1909. He has performed T6 and T2 high level of thoracic spinal for more than 1,000 cases without much complications. But when we right now to start this, we have so many fears because our minds have been incorporated that the spinal cord ends at the lower border of the L1. So performing anything above the L1 and having a needling the subarachnoid space will always lead us to a fear of an iatrogenic injury to the spinal cord. So we have various evidences to prove that this is a normal MRI, where you can see the red dot on the top of the screen, that is the C7T1 area, where you can see the spinal cord is placed almost in the posterior area. The similar picture you can also see down in T12L1 area also. Whereas you can just zoom inside over the mid-thoracics, almost from T2 to even the lower thoracic levels, you can see the spinal cord is almost placed anteriorly and the angle is also almost 45 degrees. So if you place a needle, the needle tip will be far away from the posterior surface of your spinal cord. So most of the times we perform our spinal in the lumbar regions, mostly in the sitting and in the lateral position. In 2010, Lee and et al. Has done an MRI over the thoracic spinal canal in various positions of supine, lateral, and sitting, where they could able to find that in 9 volunteers where they could consistently find there is a posterior separation of the dural sheath, and it's more pronounced in the sitting, and it's more pronounced in the mid-thoracic, that is from T6 to T9 level, and is less pronounced in T2 to T12 levels. And this could be the probable or the possible reasons that most of the times, if you have an accidental dural tap while performing a thoracic epidurals, we will not be landing up of much of neurological complication, and still we are performing a thoracic epidural still now. So the next fear that we'll always have, if I place my local anesthetic in the higher levels of T6 and T7 levels for the surgeries, will I block my cardiac axillary fibers and may cause a severe bradycardia and hypotension? Yes, that is true. When you have your spinal at the lumbar level, the sympathetic blockade is quite more, and it extends to the lower limbs and resulting in a more pronounced vasodilatation of the blood vessels and reduction of the preload. As I mentioned in my definition, it's a quite a low volume, and you're covering only a fewer dermatomes when you're trying to use a low effective anesthetic drugs. And this will block only the fewer dermatomes with minimal involvement of your lower limbs, and thereby there will be a less reduction in preload and your blood pressure. Even if you have a low blood pressure after this, it can be easily managed with little doses of your vasopressors. So what happens to my diaphragm then if the patient is going to breathe or not? So the major inspiratory muscle is your diaphragm, so which has been of its own origin of cervical nerve supply, and it is not affected. What about expiration? It's most of a passive process, and yes, you may need it when you really needed a forceful exhalation which requires your anterior abdominal muscles to contract. So having said all this fear, should I just go ahead and perform a thoracic spinal? No, that's not. So you should need something that is the most important, the patient selection. So for this, there are various factors that is going to apply for that. The first and foremost factors, that is the surgical factors. The surgical factors here on various RCTs which are done in thoracic spinal. The surgical time, the mean surgical time is ranged only to 23 to 136 minutes with a single shot. So you have to keep in mind your surgeon should be very keen and very fast enough to provide a good surgery. But you can prolong with either a combined spinal technique, or you can use a continuous spinal technique which can extend up to 190 minutes. The second most is, this is very useful in patients with very heavy impaired lung functions with severe lung diseases and frail or risk of GA and landing up in post-operative pulmonary complications. So you have to meticulously plan this type of patients when you're handling for surgery, with always having a backup of an epidural to prolong if needed. Fine. The next thing is the technical factors. These techniques are not textbooked. So this technique is very new to us, and it should not be attempted by novice anesthetists, and it should be considered once they are very proficient in the lumbar region. So always have a mentor or a senior persons with very good in it, and then start these procedures for an ASA1 patients rather than landing up and taking a very severe cases. It's better to start these because we have good evidences to prove and very good stable hemodynamics, because when I was in the state of seeing all these things, I would have also had the same fears. So to start with, start slow and go slow with the normal patients, and then show the benefits to the surgeons and to the patients of, then you can move on to the sick cases. So there are various options to provide this segmental. The things that you have to keep in mind if you're going to perform a single shot. So the things that you have to keep in mind is the surgical timing. So you can add an additives to it with a dexmedetomidine can prolong its duration. But if you really wanted to extend and give a post-operative analgesia, continuous post-operative analgesia, the options would have been a continuous spinal epidural technique. Yes, it has been proven in even severe comorbidities or frail patients, you can, like an epidural, this continuous spinal can also be titrated. So then most important thing, as I said, it covers a few dermatomes. So level identification, what surgery that you're going to give is much more important. So if you're going to do a breast surgery in the thoracic level, or an upper abdominal surgery, or you're going to perform a lower abdominal surgery, so the level of identification is much more important, which can be used with ultrasound. So ultrasound can be used as a tool to identify the level, and also the distance from the skin to the posterior complexes can be identified here. And more importantly, even in lumbar regions, when we try to perform your lumbar spinals in L3, L4 with the guidance of your tough ears or the Jacobi's line, most of the times in most of the obese parturians, will be always been given a high level of spinals. So in this, as I said, the level is more important. So you can identify the C7, T1 levels, and then know which level you really wanted to do, and you can perform with the help of the ultrasound guidance. Or you can either mark the angulations, the posterior complex and this depth, and then you can perform it. Sitting or lateral position, if you ask me, I'm comfortable with sitting, so it's up to your practice, how you're good enough to perform a thoracic. It's up to you, but sitting will be quite easier because, as I said, the positioning in supine is well placed and the space to place your needle tip will be good enough. Next, what type of needle should I use? Should I use a cutting or a pencil point needle? So if I ask me, I'll just say with the lower gauges of Quinckeys, it will be better, where you can see in Quinckeys, the tip of the needle, the distance is almost 0.2 mm. Whereas if we take other two needles, that is the pencil point, either we take or a sporty, the blind spot in front of it, it's almost comes to 1.05 to 1.25 mm. And the orifice here, it's almost about 0.8 mm. On a total, it is 2 mm. So even if you're in the correct space of the subarachnoid, you have to push 2 mm furthermore, sometimes you may get paresthesias. So it's better to use a Quinckeys to get a good amount of CSF backflow to give the drug. Yes, now the next thing is I've chosen everything. So the problem is with the thoracic is there are midline gaps between the elastic fibers of the ligamentum flavum and also the ossifications. And the interlaminar spaces are quite narrower. And there are sharply angulated spinous process from T4 to T9. So if you have difficulties in performing midline, you can always choose an option of paramedian. So how much the volume should I give? So it's almost the mean local anesthetic volume used in almost in 1,322 thoracic spinal cases for the various surgical procedures described in the literature over 15 years. It is almost 1.8 ml, because as I said at the definition, it's a fewer local and effective local anesthetic has to be used to cover the fewer dermatomes. So in theoretically, what type of local anesthetic is of your choice to use an hyperbaric or isobaric or hyperbaric. So in the case of isobaric, hyperbaric, after giving it, if you place the patient in supine because of the theoretical reasons, it's owing to the blockade of the anterior pronouncing with more motor than the sensory. But the opposite is true when you have an hyperbaric solutions, where here the sensory is more than the motor. Additives, yes, you can add it if you wanted to have a single shot with a fentanyl of 25 mics and clonidine of 30 mics and dexmedetomidine of 4 to 5 mics. In and around the Pondicherry, people have used even preservative-free ketamines and midazolam for sedations, but personally, if you ask me, I have not tried it. Then things have to be concerned is your paresthesia. Yes, even in lumbar regions, you will get paresthesia about 13.6. However, the clinical significance of this paresthesia is not known. In lumbar, yes, its accounts varies from 4 to 10%, but there is no much of long-term sequelae has been reported. So what about complete spinal block? Because I'm giving it in a higher level. So till now, pertaining to thoracic spinal anesthesia, not even a single case has been reported. But people have started using now in a very way, RCTs have been coming up in a very big way using for laparoscopic cholecystectomies. The problems that you really face is the two things. The first foremost is your surgeon. So inflating at lower pressures, go slow, they will not agree. And maintaining the intraabdominal pressure almost 12, again they will not agree. So you have to have a good rapport with your surgeons to do all those things. Yes, you may most of the times you need sedation, but sometimes you may be able to finish it off without the shoulder pains. But if you're going to have it, you can just give a preventive local irrigation under the right diaphragm, or you can manage with the systemic analgesias of 0.5 mics per kg of fentanyl or 0.5 milligram per kg of ketamines. Urinary retention, yes, this is not the way of like how it behaves like a lumbar region with a much of motor blockade, because in lumbar spinal it will accounts about 12%, but in here the segments of your lower lumbosacral segments are being spared, so you will not have much about urinary retention. Rather, I could say challenges. Patient who doesn't want to have a regional or neurosal techniques, patient who doesn't want to be awake, it will be quite challenging to make them to lie down, and those who are not giving any consent for these practices. Most important thing is the second point is the surgeons. First and foremost, that I should believe that I can perform this safely in ASA 1 and 2 patients. The second thing is you have to show how good is this, it's how cost effectiveness. So the surgeon has to believe in you. He should be satisfied. The patient also should be satisfied with good relaxation. So the confidence that you have to build up with your surgeons needs much more way to go, because it was very difficult for us when we started, and almost we are on the way of 20 cases. I'm not grown up very fast, but we are just planning still they are not accepting for laparoscopic surgeries. So the amount of gaining the confidence from the surgeon, because they are bringing the patient, so we should not land up in trouble. So that is quite very challenging for us to do it. Failed spinal, yes, even in lumbar or wherever you're going to perform the failed spinal. So what next? So should I go into convert into GA, or I can just extend if I have a safely placed in epidural? And since still in rural areas, there are current high number of malpractices even in lumbar regions, so they should not be carried about with, so okay, I can just put some 1.2 ml in the thoracic area, so and then they proceed with the mastectomy, so that should not be taken away. And in our side, we should carefully perform these procedures, because spinal cord injury 1 is disastrous, and even it is theoretically it is 1 in 10,000. If you're going to have it, you're just going to make the patient to it a rehabilitation center. And medico-legal issues, it's much more you have to face it, since these are not much about textbook things. Yes, advantages with other regional, as it also inhibits the neuroendocrine stress responses, lower the dose, so hence we have the lesser the hemodynamic changes, and we can give early mobilization and discharge with less post-operative nausea, vomiting, and can avoid post-operative pulmonary complications and the ventilatory supports. And it will give you a good post-operative analgesia, and 100% it is cost effectiveness. Just wanted to share our experiences here. This is a ASA1 patient who was well built. You can see his had a duodenal perforation 10 years back, and he had a laparotomy, following which he had a incisional hernia because of costings. He had this hernia more than 5 years and came with this presentation. You can see the bowel is almost below the skin. So we performed segmental spinal with T9, T10 level, and we gave 2 ml of 0.5% hyperbaric bupivacaine with 30 max clonidine. So the spinal was given almost in 9:30. Yes, this was his baseline. Almost we had a fall on it, and with minimal doses of ephedrine, we were able to manage the surgery. So things are the problems is which what we faced is because of the severe adhesions. You can see to dissect the skin and the subcutaneous from the bowel, because if you're going to tear it off, he is going to go into a resection anastomosis. So they almost took 2 hours with the spinal. So spinal word off. Then they started to complaining of tightness because he has to again create a rectus sheath plane for closure, placing the mesh. So we have safely had an epidural, so we just prolonged it with 8 to 10 ml of 2% lignocaine with adrenaline. And patient was comfortable, and the surgeons were comfortable, and he had a good amount of relaxation to do this surgery. And you can almost see the incision extending from T6. So it's another thing is another sick patient where we had a 66-old male with diabetes and hypertension with a severe COPD with a moderate pulmonary hypertension. Initially, it was planned for a truncal vagotomy and GJ for the GU. We performed the epidural at T7, T9 and spinal of T8, T9 with the 2 ml of 0.7%. I just get 2 more minutes. With the 30 max clonidine with the Kitadex sedation was being used. Unfortunately, we had a Mersey syndrome of obstruction of the gallbladder, and we had a nice additions intraoperatively. Now the plan was B. So he has to undergo a cholecystectomy and a planned truncal vagotomy with the GJ. So since we had a epidural, since these are the cases where we started earlier, so we always had a backup plan of an epidural, so we could able to extend it after 2 hours with 5 ml of 0.5% bupivacaine, and then again we repeated with 4 ml, and the patient was given continuous analgesia with epidural catheter till post-operative too. So there are various evidences now coming up with the case reports, and RCTs have been come up. So is it safe to perform? So anesthetic technique, most of the patients will end up in GA or neuraxial techniques will be given. All these techniques will have their own advantages and disadvantages and procedure specific risks. But small subset of patients where there's the challenge. So the procedure or the patient specific factors will dictate the choice of anesthesia. So always regional anesthesia has had an upper hand in this type of patients. And any contraindications for the spinal will also apply for the thoracic segmental. It is not an alternative. And segmental spinal, yes, it is safe because which has been incorporated into our armamentarium due to the increasing number of anesthetists have been performing this, and it can be safely, feasibly, and it is an effective alternative anesthetic technique and may be used in patients where other anesthetic technique poses a higher risk. The main important thing to conclude is it is safe, but to practice it safely, it needs a good learning curve. Thank you. Thank you all.